Chapter 45. Again, I'll apologize for the sound of my voice. It's been just getting over bronchitis. Finally, after several days of not having a voice, have something left, or something to at least give you a little bit of a lecture with. So in Chapter 45, we're going to cover geriatrics. Of course, geriatrics being a significant amount of the population that we serve within EMS. There are some very distinct differences between the geriatric population and the typical adult population, probably just as many as there are between the differences between the pediatric population and the adult population. So we'll touch on those in this chapter. As with all of our chapters, if you have not read and studied the chapter on your own, please do so as soon as possible. By simply listening or watching this lecture is no replacement for studying on your own. Again, the AEMT will be able to apply the fundamental knowledge of growth, development, aging, and assessment findings to provide basic and selected advanced emergency care and transportation for a patient with special needs. A couple of multimedia videos and the non-narrated PowerPoint. And of course, we have our objectives, and you can find all those objectives on pages 996 and 997 in your textbook. Okay, so the U.S. population age 65 and older is going to continue to increase. It's increasing and will continue to increase. The post-World War II baby boom is all now reaching the age of retirement, or retirement age, I guess. They're getting into their 60s, and some of them have already started to retire. And obviously, the older we get, typically, the more medical problems that we have. The baby boom that followed the Second World War created a very large generation of people, and now with all of them beginning to retire, not only is it causing EMS to have more calls for the aging population, but also a significant number of people who have spent their career as EMS providers, whether that be a volunteer or in a paid career, are also now leaving the field, and it's starting to put a little strain really on all the healthcare fields. So nursing shortage is going to continue, and of course we're constantly in a shortage for physicians, particularly in rural areas. So common reasons that the older adults may require EMS: cardiac and respiratory problems, neurologic problems, injuries from falls, and then nonspecific complaints. Of course, the cardiac issues come with patients who grew up actually lived a significant portion of their adulthood when we were transitioning into a more mobile and fast food society. So it has taken its toll on them as well. Granted, they maybe didn't initially learn that, but over time, it certainly has affected their life. Probably not as much as it's going to those of us that are the post-baby boomer generation, in which most of us are overweight and have become accustomed to a pretty sedentary lifestyle. Neurologic problems such as strokes, we know that those are often related to the vascular disease, the same causes of cardiac problems as well. Injuries from falls, that's just in general. The older you get, the less muscle mass you have, the weaker bone mass that you have, and the more likely that you will be unstable on your feet, as well as suffer a an actual injury when you do fall. And then with the body aging, the neurologic system becomes less sensitive. All the patient's senses are becoming less acute, and so things become less specific and much more generalized, and that's where we get some of these non-specific complaints. I just don't feel good. If you remember back to the cardiac chapter, we talked about the 3 major patient categories that have atypical heart attacks, being the elderly, the diabetics, and females. So, patient assessment care applicable for older patients. They do have some special considerations because their body has changed. Take, for example, people with kyphosis of the spine, where they have large humpback. You can't lay them flat. So that's just one of many. So a couple of terms that come up here is geriatrics and gerontology. Geriatrics is the branch of medicine that specializes in treating the elderly, and gerontology is a much more general term that refers to the study of aging. So it may not be specifically related to medicine. It may be more just the general life of the elderly. With your case study. All right, so our average life expectancy now is 77.9 years, and a lot of things have attributed to this. Things that will affect your life expectancy include things such as your gender. Women tend to live longer than men. Genetics, as part of the process of natural selection and the process of evolution. We've bred stronger races of people, and the environment. The environment is probably one of the more one of the bigger reasons for us to have longer life expectancies when we consider the things that medicine has changed so much in our environment. So when we have a healthier environment in one respect, when we say we have modern medicine that has some significant advantages, it certainly is going to extend life of the human race. But we also have a negative factor of the environment. Much of what is making our life better is making our lives worse. So what I mean by that is we see so much of so many different diseases that are now big problems that weren't problems 50 years ago or 100 years ago. Whether it's something that's related to certain chemicals that we've introduced in that time. Maybe it's that we have such a sedentary lifestyle, which leads on to the lifestyle in the next factor there. But or is it that life is so much different that we don't take the same risks or do the same things that we used to. And of course, lifestyle. Now I anticipate that we're going to continue to see problems with heart disease and vascular problems for beyond the baby boomer generation, probably into my generation, will continue to climb. I guess I'm kind of excited to see what happens when the next generation comes around, because it appears to me, at least, that the next generation certainly has a better grasp on this healthier living thing than my generation does. Not that it excludes anybody in particular, but you kind of see the generational changes. So age-related decline in the body system's function. This decrease ability to maintain homeostasis due to anatomic and physiologic changes. So this may be things such as the inability of our hypothalamus to continue to keep our body at a normal temperature. Temperature regulation is worn out. Maybe due to changes in how much body fat we have or how much muscle mass we have. Remember, the more muscle mass you have, the more energy it takes just for you to exist in the room. So therefore, you burn more energy, you stay warmer. As you lose muscle mass, you're not burning as much energy, you're not creating as much waste product. That waste product of burning energy is heat. So perhaps it's changes in the vessels, because the vessels are now becoming clogged with fatty plaques and whatnot. Maybe it's changes in lung compliance. So there's lots of potentials that are going to change our homeostasis. So just a few of the age-related changes and their significance. You can see this chart on page 1000 in your textbook. So the age-related changes such as the senses. So we have thickening of the lenses of the eye. It's going to cause changes in vision. You may have cataracts. Cataracts, you kind of get this clouding of the vision where you get an opaque or a semi-opaque plaque that kind of forms directly in your line of sight. Macular degeneration. The macula is on the back of your eye, and it's directly related to your optic nerve, so you lose some of your central vision. Glaucoma, where you start to lose some of your peripheral vision, buildup of excess pressures within the eyeball. Changes within the inner ear structure causes decreased hearing, especially at high tones, and dizziness. Changes in your pain sensitivity. They may not feel the injuries quite as much. I've responded to a number of calls in which somebody actually became injured. They called us for something else and didn't realize that they were bleeding all over the place. Didn't realize that there's this large laceration on their leg. And then decrease in taste and smell. So they may not enjoy their food quite as much. So maybe they just don't eat quite as much. So neurologically, the structural and functional brain changes. The brain can start to atrophy or can shrink a little bit, commonly seen in people with Alzheimer's disease. Dementia may set in. Memory impairments, slowed learning, depression, slowed reactions, impaired proprioception. With cardiovascular, we have things such as atherosclerotic changes. We know that atherosclerosis is a hardening of the arteries, and that is specific to fat plaque formations, and this can lead to all kinds of issues, many of which we've talked about throughout this course. Hypertension, acute coronary syndromes, basically MIs, strokes, a mesenteric infarct, or you can develop a blood clot in your blood supply to your intestines. Remember, they need blood too. So you cut off the blood supply to there, they will die. A renal infarct, aortic dissection, aneurysms. May have cardiac conduction system changes, such as building dysrhythmias. Dysrhythmia meaning that the rhythm is off or bad. You may have a decreased maximum heart rate. There are two kind of major camps that we see the elderly population in. We have those people who have heart rates higher than normal. They typically have a condition called atrial fibrillation. So they have this higher heart rate, and it's very irregular. Typically it's 90, 100, 110, 120. Or we have the other camp in which people who have basically burned out their SA node in their heart, and they're relying now on the backup pacemaker, which is the AV node of the heart, And those people tend to be bradycardic, so they may be in the 40s and 50s. They may have something called sick sinus syndrome, in which it's kind of like a flickering. Sometimes it works and sometimes it doesn't. And next thing you know, it's not functioning at all. And those are the people who end up with pacemakers. And then myocardial changes, decreased cardiac output. As that heart muscle starts to wear out, it doesn't have the kick and the stretch that it used to. And in those cases, we start to see issues with them being able to maintain an appropriate blood pressure. In the respiratory tract, we have changes in the chest wall compliance. Things are starting to become stiff. It's harder to move that chest wall upward and outward. Their cough and gag reflexes are decreasing, so they're at a higher risk of infection in there. Decreased gas exchange. They maybe have worn out, started to wear out their alveoli. So their alveoli are all stretched out and they don't have much kick. It's harder to get stuff through there. Gastrointestinally, they have decrease in their stomach acids, digestive enzymes, so they don't absorb nutrients quite as well. More stuff just goes through unprocessed. Decreased gastrointestinal motility, so they don't move stuff quite as quick and they become constipated. It's a major, major thing for the elderly population. Sometimes that's their whole life surrounds their bowel movements. The things that they're worried about for the day in the nursing home many times is, did I eat, did I poop, and when is nap time? It's sad to say, but it's really kind of true. Decreased liver function. They don't produce as many proteins and enzymes that they used to. They don't clear their drugs like they used to, so sometimes you'll see drugs marked with cautions in the elderly population, that you have to watch them closely to make sure that they're not building up drugs in their system. Genitourinary and renal. Their decreased renal function, kidneys are wearing out, so they're not eliminating substances quite as easily. Again, can lead to a drug toxicity. Impaired bladder function. Either they get urinary retention, which is fairly common in men because of actually a problem with the prostate gland being hypertrophied or overgrown, where they get urinary retention. They may get urinary tract infections if they retain urine. Or there's the other side of it in which they become urinary incontinent. They can't hold their urine. The immune system, all of that just generally declines, raises their risk of infection. They may not have a fever. Musculoskeletal system, they lose that muscle mass, so higher risk of falls. They're not as mobile. Maybe can't even get themselves up after falling. Many, many times in my career have I responded to patients who have been down for days on end and laid on the floor for 2, 3, 4 days. Most of them don't make it after laying on the floor, say about 4 days at the max. If they've laid there much longer, then usually it's not a good outcome. And even laying on the floor for 2 or 3 or 4 days may not have a great outcome, because usually that they're going to come down with some infections and they get rhabdomyolysis, which they've broken down so many tissues, and now they flood their kidneys and basically have clogged the kidneys up. The musculoskeletal system, they lose their, I already mentioned that, sorry, osteoporosis and osteoarthritis. Osteoporosis is the weakening of the bones because the calcium and phosphates and whatnot are being pulled, they're being robbed from the bones, and so therefore the bones become much more porous. Osteoarthritis, remember, that occurs in the joints. So as we've worn out those linings in the joints, it's kind of like, think about your weather stripping around your windows and doors. Over time it wears down and makes it so, it doesn't work as well. This is kind of the opposite. of actually breaking down. Sometimes maybe is overgrown, so things don't move quite as easily and nicely as they used to. Integumentary, the skin has become thin, doesn't protect them as well. It rips easily. Sometimes people have that paper thin skin. Lose their elasticity, higher risk for decubitus ulcers. When the skin is not in good shape and then you have a weakened musculoskeletal system and a weakened immune system, makes it that much easier for bed sores to evolve. Their thermoregulation system, again, they have decreased ability to sweat and to shiver and therefore have harder times maintaining a decent body temperature. And that can lead to either heat or cold related emergencies. Okay, a little more on the neurologic system. We mentioned that the brain changes with age. It's common for depression to be seen in the elderly population. Sometimes the elderly population feel like they're a burden. They may also feel like many of their friends are dying, their loved ones are dying, and that of course is depressive. Sometimes they've kind of lost their sense of self-worth because they're not working. And even though they've worked their entire life, they sometimes feel like, I'm not a contributing member of society anymore, and that's just not true. But it's hard. It's hard for them to recognize this and realize this. Suicide in the elderly population is actually probably higher than most people would initially think. Altered mental status is fairly common as well, whether this is as a result of, say, their dementias. Perhaps they have some Alzheimer's issues. There's an interesting phenomenon that occurs with Alzheimer's patients. It's called sundowner syndrome, and it really does follow the day-night cycles, in which patients will have really kind of one demeanor during the day and a completely different demeanor after the sun goes down. And a lot of times, it's a pretty calm demeanor during the day, and it's a not so calm demeanor at night. So it has to do a little bit with circadian rhythms and whatnot. But remember, Alzheimer's remains a disease diagnosis of exclusion. Really, the only real way to formally diagnose Alzheimer's is on autopsy. So, but another common thing that they see with that is that brain atrophy, that the brain shrunk up. So cardiovascular hypertension is common. Probably the most common, probably the most commonly treated condition in the United States is hypertension. So a lot of people with hypertension, and it's becoming a younger and younger person's problem. So when we have these things, the diet that we have and the sedentary lifestyle that we have, they're not helping it at all. Changes in the heart rate and rhythm, I've mentioned those already. Very common to see elderly patients in atrial fibrillation or in a bradycardia. So more common than not, it's atrial fibrillation. In fact, atrial fibrillation has been nicknamed the nursing home rhythm for the fact that a significant majority of the people that we see in the nursing home have AFib. GI, constipation, deterioration of structures in the mouth. Remember, many of our elderly patients have dentures, and those dentures don't always fit well. They don't always do quite as good of a job as do natural teeth, so it can become harder for them to eat. Not to mention the losses of gag reflex makes them a little more risk for aspiration. So we get a problem that's kind of a double dipper. You have a gastrointestinal issue because their swallowing abilities are not quite as good as they used to be. They suck something into a lung, and now they have a respiratory issue. Decline in efficiency of the liver. Remember, the liver has hundreds of jobs that it does. Impaired swallowing, malnutrition. Sometimes the malnutrition is due to medical conditions that they have, but also remember that malnutrition certainly could be from a socioeconomic standpoint. Many elderly patients living off of very limited incomes, and that limited income can they may have to choose, am I going to have electricity and heat, or am I going to have food to eat? There have been several times that I've gone into elderly patients' houses and found that they eat pet food because it's cheap. Sad but true. We mentioned osteoporosis and arthritis. The coughing power is diminished in the respiratory system, so if they start to choke on something, again, higher risk for them to suck something into their lung and get an aspiration pneumonia. Aspiration pneumonia is when you have inhaled something that you should have either swallowed or vomited. So, and they have that less air and gas exchange. Drug toxicity can be a huge problem for these people with both the renal and the hepatic or the liver system, because those are the two major systems that detoxify or metabolize many of our medications and drugs. So when they're under fire or when they're not functioning at capacity, what would be considered a normal dose for many of us maybe becomes now an overdose because they didn't break down that drug in 8 hours like they were supposed to. It takes them now 12 hours to break down what should have taken them 8 hours. But we still give them that same drug every 8 hours. There's constantly a little bit left over, a little bit left over, a little bit left over, and it just continues to build. The skin, they perspire less. Obviously, they don't sweat quite as much. Many of the elderly complain of it being cold much of the time, and so we often will see them in sweaters. You go into many of the nursing facilities or even a lot of elderly patients' homes, and it's quite warm in there. In a portion of my career, part of our extra duties when we weren't running ambulance calls, we would go and do blood draws, venous blood draws for the lab at our hospital. And we would always have to be very cautious on if we knew that was a day we were going to be going to the nursing home to draw blood and it was in the middle of winter. We would really actually want to make sure that we dressed down for the occasion because we knew we were going to be sweating our butts off in the nursing home if we wore extra layers. So you dressed down for the occasion and in hopes that you didn't have a call early that morning before you put on some extra layers. The skin tear is obviously pretty easy in many of these patients. I'm hoping, it's kind of weird to hope this, but I'm hoping that many of you have been able to experience just how tender and gentle some of these patients' skin is, particularly when you're starting IVs on them. You know, how a little prick or poke actually can set off a pretty good tear. They heal much slower. Immune system, we've already mentioned those. The changes in vision. You know, there's so many different things that could potentially affect the vision. You know, that most of them get presbyopia, where they actually have nearsightedness, so they don't see things well far away, but they maybe have lost vision in different ranges, and that's why many elderly patients have multifocal lenses, bi or even trifocal lenses, so they can see stuff up close and stuff far away and stuff intermediate. Just last year when I had my vision checked, the eye doctor recommended even putting myself into bifocals, and at the ripe old age of 41, I was a little taken aback by that. But so I tried bifocals, and holy cow, I can't tell you how messed up that made me. But so changes in vision. I've worn glasses much of my life, and it's they don't tend to get better. So, age-related hearing loss, whether it's occupational, say from people who worked around machinery, or just as a natural age-related loss from the nerves becoming less and less efficient. Weight control, whether that is onto the obese side, or even many of them are malnourished enough that they are actually underweight. I think one that they leave out of here is most elderly people are also dehydrated, chronically dehydrated. I would say a significant majority of the American population is significantly dehydrated. Because we don't do a good job of watching our water intake, and there's so many other tasty beverages out there like coffee and tea and cola and whatnot that all have caffeine that constantly dehydrate us. Type 2 diabetes, where they've lived a certain lifestyle of too much sugar, too much refined sugars, that their body no longer can create appropriate levels of insulin to balance it out. And then, of course, an increased incidence of cancer. I think a lot of this also has to do with the lifestyle as well. If somebody who was constantly playing in the chemicals, or somebody who was, we thought that if you insulated things with asbestos 75 or 100 years ago, man, that's a great insulator. Well, I've come to find out it's also really great at giving you cancer. Menopause in women, usually in the late 40s or the early 50s, women will enter menopause, in which they stop having a regular menstrual period. They quote unquote end their cycle of fertility, although that's it's not an instant on, instant off sort of thing. As women hit menopause, many of their risk factors for certain conditions rise dramatically, such as cardiovascular issues and osteoporosis. Skin becomes more pale, the hair becomes white or gray, it thins, our muscle mass decreases, skeletal muscles weaken up. Fractures can occur with minimal force, sometimes with hardly any force at all. Sometimes just a matter of constantly sitting and not getting up and doing anything can be enough to cause some compression fractures, or some even pathologic fractures if you've got other medical conditions. We know that the blood vessels thicken with atherosclerosis and increases their systemic vascular resistance. It's harder for their heart to work. So their heart actually starts to work a little harder, probably starts to start them down the road of congestive heart failure. Organs aren't perfused as well, so there's not as much blood getting out where it needs to go. Hypertension is a huge problem. Anemia and a decreased response to infection. The body just doesn't have those reserves anymore. So the elderly population, they don't carry as much red cells, they don't have as much hemoglobin, they may not have the ability to make as many red cells anymore. Decline in the respiratory system. It's been breathing in this crappy, smoggy, dirty air for 60, 70, 80 years, and it's now starting to take its toll. Decreases in the senses of taste and smell, the dental issues that we've already mentioned. Less insulin production, therefore glucose metabolism becomes a bigger issue. The liver function starts to decrease. Remember, the liver function really has a lot to do with the metabolism and the use of the various nutrients that are brought into the patient's body. They have decreased sensory functions, reaction times. That's why sometimes we hear of people having issues, obviously as they age, becoming worse drivers. They have proprioception, which is their sensation of the orientation of their body without visual input. So basically knowing where you're at in time and space. So if you put your arms straight out in front of you and you did this with your eyes closed, it may be difficult for you to know exactly where are my arms at. Vascular disease and inflammatory process certainly can lead to dementia. Some other things such as Parkinson's disease come from breakdown in the ability to produce dopamine. Their pain perception decreases. Okay, so sometimes EMS providers are the only ones with the opportunity to provide surveillance for health problems, safety problems in the homes of the elderly. Something that I've mentioned from time to time is the concept of community paramedicine, or what is probably now becoming better known as mobile integrated healthcare. This is a concept that's being used in other parts of the world and in some parts of the United States, in which EMS is being enlisted to assist in keeping people out of the hospital. And with this, it may involve some home visits. Now, this model can be modified dramatically depending on what the needs of the community are and the abilities of the service are. But this might be something that if you are in a career service, that you, between calls, maybe are stopping by patients' houses and just checking in on them to make sure that that congestive heart failure patient hasn't put on a bunch of weight. You know, maybe the person was discharged from the hospital a week ago and in the period of 7 days has put on about 20 pounds. Well, a good chance is if they put on that much weight that fast, it's mostly water. So it could be, another onset of congestive heart failure. Maybe it's we're stopping in to see somebody who fell at home and we notice that they have loose rugs or they have a loose floorboard or something. These are some of those concepts that are going to change the way that EMS is operating, because the hospitals aren't getting paid when patients come back immediately for the same problem. And so the hospitals are starting to realize, hey, we've got those guys out there with trucks that maybe can go out and see those patients and just make sure everything's okay. It's not adding anything really new to our toolbox. It's just adding a different way to look at it and saying, how can we be part of the solution to keep people from going to the hospital all the time? We all have these frequent flyers that we've dealt with. How can we change the system? How can we make it so they're not constantly going back to the hospital? Other things to think about: food, shopping, transportation, home repairs, doctor visits, utility payments, tasks, services sometimes are out of reach for the elderly. They maybe don't have the resources. I've already mentioned they're on limited incomes. They may have to make a decision. Am I going to have heat or am I going to have food? So, and it's things that we may take for granted. You know, retirement isn't easy for a lot of people. 97% of those 65 and older, 13% 85 and older are living below the poverty line. So there's a lot of people who are struggling in order to keep ends meeting. Lack of adequate income and social support can also be very dangerous. They maybe don't have any idea who can they call to take them to the hospital. take them to the doctor. They may end up skipping doctor visits because they can't afford a taxi or nobody can take them. And so that's sometimes where we can help fill the gaps. We can get them in touch with somebody who can take them there. Maybe we know, maybe our ambulance service we work for also does paratransit or wheelchair vans. So we can hook them up with that and say, here's a way to get this done. So they lose their function, their independence, they may lose their companions, and obviously financial burdens are, of course, huge. Financial and physical dependence can also raise the possibility of abuse and neglect, which is obviously, obviously nothing that anybody is ever wishing for. But it's probably something that gets overlooked. We talk about domestic abuse. We talk about child abuse. We don't talk about and think about dependent adult abuse very often. Sometimes people see, their elderly mother or father as a cash cow because, oh, yeah, we got that Medicare check coming in once a month, which Medicare doesn't pay a whole lot out to begin with. Okay, so there's that video. So factors associated with an increased risk for elder abuse. The patient's 80 or older, female, financially or physically dependent on others, immobile, incontinent, have dementia, sleep disturbances, and multiple medical problems. So things can become complicated, and the more reliant they are, probably the more of a risk they are. Abuser factors, there can be lots of different things. There can be numerous stressors in addition to caring for the patient. Maybe the abuser is also not doing well financially. Maybe the abuser has been abused in the past. It might be a family member, and in most cases, I would say it probably is. Maybe a caregiver. This does come up from time to time, that nursing homes or hospitals or assisted living centers or whatever have an occasional case in which somebody gets abused in their facility. But it tends to be the exception rather than the rule, thankfully. Depression and suicide, I've already kind of alluded to this. It's becoming probably more prevalent, but it's not talked about. There's a lot of pressure, particularly if you're becoming one of the lone survivors of your peer group and your loved ones. A majority of the elderly live independently with minimal assistance or with family members. Think about this. Think back to your teen years, how all you were striving for was to become independent, to be your own person, and to get out on your own. And when I'm all grown up, this is the way I'm going to do this. And now, once we're, once you're becoming an elder, now we're moving backwards. So you're losing some of your independence. You're losing your ability to drive. You're losing your ability to care for yourself. And think about how that might affect you. So always attempt to communicate directly with the older patient first. A lot of times we are going to get that helicopter family member who wants to try to give you all the answers. And it's okay to tell that family member, I appreciate that. I want to see what sort of answers I get out of your mother or out of your father here, and then we'll compare notes so I can detect, how alert and how oriented they are. Granted, you may not actually be looking for that orientation, but that's an excuse you can give them to say, hey, let's do this so I can kind of get a baseline of where they are in the world. Do not assume that they will give you an unreliable history or ask others about him. One thing that I myself am terrible about is I have been known to instantly assume that elderly people have hearing loss. I don't know if it's because I myself have hearing loss, but I instantly, probably pipe up a little higher than necessary. And I've been told several times, I can hear you just fine. Rely on others for information only if you're unable to get a satisfactory history from the patient themselves. Sometimes they'll be able to give us a lot of good information, but sometimes things just don't jive. Video on Alzheimer's. Okay, so we'll talk a little bit about general assessment and management. So on our scene size up, look for those potential hazards. And as I say look for those potential hazards, I really am saying look not only for things that are hazardous at the scene immediately, but things that have the potential to be hazardous in the long run. So do we have the potential for violence, for abuse, down power lines, vicious ankle-biting dogs, whatever, but also being proactive. Can we take and make a teachable moment, say, okay, can we help you with this rug? I notice that there's no backing and this rug moves very easily. I've noticed that stair out front is coming apart, or the railing is loose, or whatever. That's also things to look for. Is it an immediate problem? No, but this is perhaps something that we need to take note of for the future, whether we're talking with the patient at another time, or we're going to have some contact with the patient's family member, or maybe we can just be a good Samaritan and help them out. Determine the number of patients. In most cases, of course, it is one, but elderly population, I'm starting to feel sick. Come to find out, the wife's feeling sick too, and they both have headaches, and the furnace has recently come on. You still run that same risk of carbon monoxide or other toxic environment. Determine the nature of illness or the mechanism of injury. Sometimes that's difficult in itself because of the vague complaints that we get. Obtain that chief complaint and try to develop a general impression. Pay attention to their surroundings. Look for indications of chronic illness. This is really when looking for scene clues can be extremely helpful. Am I seeing pill bottles? Am I seeing pill sorters? Is there an oxygen source? Do I see 900 feet of nasal cannula strung throughout the house? Are there walkers? Are there bed lifts? Incontinence pads? Do they have a little booster seat on the toilet that helps them use the toilet a little easier? Or commodes or urinals? There's so many different potentials. Look for CPAP devices and whatnot. Assess their degree of mobility. Are they truly able to get to the things that they need to get to? Are they able to actually get into their bathtub and keep themselves clean? Or is that almost impossible because they can't lift their leg that high to get it over the tub rail? Of course, obtain their chief complaint. So again, try to communicate with your elderly patient first, turning to others if you can't get the full history from the patient, or to obtain additional information. And maybe you need to talk to a family member or bystander and find out what is normal for this person and what are they showing us now. We're going to attempt to get a single specific chief complaint, but again, that's sometimes very difficult. Sometimes we just get, I don't feel good. So we have to dig a little more. Avoid attributing signs and symptoms of disease to the aging process. So attempt to assign them to a medical condition, but also understand that they may also be something normal. Determine the patient's normal or baseline condition. I've already mentioned that, how we may need to talk to the family members. Some people maybe would not be concerned with a patient who has a blood pressure of 120/84. Well, that sounds like a pretty good blood pressure. but you see that the patient's on 3 medications for hypertension, and you talk to the family member, or you look at the patient's journal, or you talk to the home health aide or whatever, and find out, well, that patient's blood pressure is normally in the 150s over 92. Well, then this patient is technically hypotensive in a relative sense, because that patient's body is used to running a much higher blood pressure. And now, even though this blood pressure is normal, at least in our eyes, it's not normal for this patient. It's very low for this patient. If they're unresponsive and does not appear to be breathing normally, confirm their unresponsiveness. Check a carotid pulse. If you don't detect a pulse, within 10 seconds, begin chest compressions unless you're presented with a current valid signed DNR order in a timely manner. You're going to have to know what your local protocols are, what you can and cannot accept. There are more and more places now looking at getting some uniformity in their advanced directives and do not resuscitate orders, and I think that's only going to benefit us in the long run. If they're responsive or unresponsive but have a pulse, then we continue the ABCs. So begin with airway, go to breathing, and then circulation. We treat as we go. So if we have an airway compromise, fix it. Breathing problem, fix it. They're hypoxic, fix it. Bleeding, shock, fix it before you continue on to secondary. So we can open and maintain the airway. This can be made difficult by the absence of teeth or poorly fitting dentures. If you have poorly fitting dentures, ones that aren't well secured, remove them. If they're in their firm, leave them alone. So if we try to lay our patient flat on their back, they have that kyphosis or that hump, trying to get them to lay flat is actually going to worsen their condition. We sometimes have to get creative with the use of pillows and blankets and towels to kind of build up a little nest to give them support. Using the jaw thrust maneuver or modified jaw thrust may be necessary. You can't crank back on their head. Use of positioning, suctioning, manual maneuvers, basic and advanced airways as needed. Observe for signs of respiratory distress. Provide ventilations as necessary. If you need to simply assist them with their ventilations. I've had elderly patients that I've talked to who are working so hard to breathe, and I ask them, do you want me to breathe for you? And just get them to shake their head yes. And you put the mask on, and the first couple of breaths is kind of difficult because you're trying to get timing down. But after a couple of breaths, they really learn to trust you and to kind of go with you, and you breathe along with them. As they start to inhale, you kind of assist. It is common for the elderly patients to have an irregular pulse. That's a characteristic of atrial fibrillation. However, the irregular pulse can also be a sign of hypoperfusion and or a lethal dysrhythmia. So in and of itself, an irregular pulse isn't always a bad thing, but understand that sometimes it is a sign of a really bad thing. People who have AFib and are still in the same rate and rhythm that they have been for weeks and months and years on end is not a big deal. But somebody who's new to it could potentially be an issue. Controlling bleeding using direct pressure. Understand that many elderly patients are also on blood thinners, whether it's something simple like aspirin or something more complex like Coumadin or Pradaxa. And then determine their priority for treatment and transport. So some common complaints of the elderly and their significance. This chart can be found on 1003 in your text. So they may be complaining of abdominal pain or discomfort. That could be anything from acute coronary syndrome, which is a heart problem, aortic dissection or aneurysm, that could be up in their chest, bowel infarction or obstruction, that's or obstruction. That's actually pretty common. Gastroenteritis, or basically an inflammation of the gastrointestinal tract. Gastrointestinal bleeding, very, very common in the elderly. Just imagine being on blood thinners and then you develop some sort of a sore or a wound or a lesion in your gut, and it just continues to bleed. Pneumonia. Pneumonia, again, is a lung problem. Remember, it's hard for them to pinpoint. It's hard for them to be exact. That on top of referred pain or even radiation of pain may make it seem like it's not where it really actually is occurring. Altered mental status. Dementia and delirium. Remember, dementia is a chronic long-term problem. Delirium is a kind of a new quick onset thing where maybe they were fine yesterday, but now today they're 8 shades of crazy. Renal failure, or hepatic failure, sorry. Liver failure. Renal failure is further down. Remember, they're building up toxins or they're building up drugs. Hypoglycemia. Remember, either one of those causes changes in mental status. Hypoperfusion, hypo or hyperthermia, hypoxia, infection, medications or toxins, seizures, strokes, substance abuse. Maybe it was intentional, maybe it wasn't. And trauma. Dyspnea could be acute coronary syndrome. Remember, a lot of times that people with chest pains are complaining of shortness of breath, rightfully so, because their body is sensing some hypoxia. And sometimes this is the only symptom that they'll complain of. Anemia. Now, anemia doesn't have anything to do with their breathing, but it's a lack of blood's ability to carry oxygen, and the body says, well, if I don't have the ability to carry it, I need to have more of it in me. Asthma, COPD, heart failure, again, a heart problem that shows up as a lung issue. Infections, lung cancer, pneumothorax, pulmonary embolism, so chest pain or discomfort, maybe acute coronary syndromes, hiatal hernia. Remember, that's actually a gastrointestinal problem. Part of their stomach is popped up over the top of the diaphragm, and it's actually collecting a little bit of acid on the north side of the diaphragm. Musculoskeletal pain. They fell down, they hit their chest on a table, and now they have a couple of broken ribs. Pneumonia, pulmonary embolism. Syncope. Remember, most cases syncope is of cardiac origin until proven otherwise. So whether that's as a result of an acute coronary syndrome, they had a coronary dysrhythmia, could be from hypovolemia, so maybe that GI bleed has led them to have a syncopal episode. Certain medications, because their body isn't able to compensate quite as quickly due to that medication. Vasovagal syncope. That's when they're sitting on the toilet and they strain real hard because they're constipated and they put too much stimulus on the vagus nerve, drops their heart rate. Weakness and fatigue. That can be just about anything. Acute coronary syndrome, anemia, dehydration, electrolyte imbalance, infection, medications, hypothyroidism, stroke. So then as we progress on to the secondary assessment, determine by whether the nature of the problem is medical or traumatic, and whether they're critical or non-critical. Medical problems and trauma can overlap in the elderly patient. They can overlap in any patient, but it seems to be more characteristic to have somebody get hurt as a result of their medical condition. They had a syncopal episode because they are having a GI bleed, and now they've fallen down and they've hit their head or they've broken their arm. Also, in many cases of motor vehicle collisions. Motor vehicle collisions being caused by a medical condition, pretty common in the elderly. Assess the mental status can be challenging. You may have a patient with dementia. They may have an alteration of mental status as part of their baseline condition. So again, somebody who is residing in an Alzheimer's ward, no, they don't get a 15 on the Glasgow Coma Scale, but they never get a 15 on the Glasgow Coma Scale because they're never oriented. So knowing what you started with and what you have now, or what's normal and what you have now, is huge. That's why talking to other people is very important. Other things such as, well, here's an interesting one. I've had a time or two. I've been called to a nursing home for a patient whose mental status is actually better than normal. That's a hard one to justify, I think, because you're like, really? They seem more normal? Okay, well, I guess we'll take them in and find out what's going on. So again, continue to use your AVPU, and then you can use your mini mental status exam, or simply asking them the simple questions of person, place, time, president. Introduce yourself, speak slowly and clearly, and position yourself where the patient can see you. If the patient's answering questions slowly, you may need to give them additional time. They may not be able to process your question quite as quickly. They may also have issues with their speech. So use responses to monitor their mental status. So sometimes they initially look like they're doing okay, but then some of the answers to your questions are way off base. Well, sometimes their cognitive functions are impaired. They're simple everyday stuff that they're very good at, but other more complex and abstract things that are difficult for them. Note that they may also be confabulating, so patient unknowingly filling gaps in the memory with information that seems to fit. So sometimes they quote unquote are making up stuff. They're drawing either maybe from a different time in their life or drawing from a story that somebody else told, and they're not intentionally doing it, but sometimes they're bringing this big long story, and it's usually pretty easy to see through, but to them it seems real. Note that you can get additional information from family members and caretakers and whatnot. The nursing homes have, and when we go to nursing homes, we sometimes have the advantage of being able to take a medication sheet with us. And normally on most patient med sheets, they also have their allergies listed, and in many cases their medical history. So that helps us. Simply picking up the pill sorter, the Monday through Friday with 4 different levels for morning, noon, afternoon, and night, makes it determining the medications difficult. So if we can find the bottles with the labels, that's the best thing to take with us. Try to obtain a complete history as possible using sample and OPQRST. Try to obtain a complete medication history. If they have those little pill sorters, look at them. See, have they been taking all the pills when they're supposed to? Or do we have some in which they missed a dose this day or that day or the next day? Also, if you pay attention to the dates that pills were filled on the bottle, and note how many pills are left in the bottle. Have they been accidentally overdosing themselves because they're forgetful? We have polypharmacy issues going on a lot of times. A lot of times we have patients that are seeing multiple doctors, and multiple doctors have multiple requests and orders. Sometimes the communication between doctors isn't so great, And so a patient could put on a couple of meds, maybe the same med twice, or maybe two meds that actually compete against each other or antagonize each other. So a lot of times that's where we hope that the pharmacist catches that. Always consider medications as a potential cause or contributing factor of a problem. Maybe we have a patient who is constantly passing out and they're hypotensive, or they have slow heart rate. And we come to find out that they're on a beta blocker, and maybe they're taking a little too much. The doctor's just adjusted their dose. So that's always something that you can have to think twice about. So bringing those meds along, bringing along the med sheets or the pill bottles is very, very helpful. So vital signs are generally similar to those of other adults, although slightly higher than most adults that are, in the prime. Normal vital signs do not rule out the presence of a significant illness or injury. Because remember, if they're used to running higher than normal, a normal set to us currently maybe isn't telling us the whole picture. Medications for hypertension or other conditions can cause hypotension, orthostatic hypotension, syncope, near syncope. In our critical patients, we're going to do our rapid exams, whether it's rapid medical or rapid trauma, gather that chief complaint, the medical history, and we're going to focus our physical exam for the non-critical patients. And for trauma patients, look for mechanisms and chief complaints to guide us in our focused physical exam. As we have time, we may do a detailed head to toe. Other things to keep in mind. The elderly often are cold, so they dress in layers. I've had a number of elderly patients that have had 3 or 4 or 5 layers on. Don't cut the clothes unless medically necessary to do so. Try to help them remove it if necessary. Keep them covered. Keep them warm. They may have limited range of motion, so it might not be easy for them to take a sweater off or a jacket off. So be patient, be gentle. Some of the elderly have decreased sensitivity to pain and may not complain the level of pain expected. You might look at something and go, oh my God, that's got to hurt. And they're barely noticing it. It's a neurologic issue. Example of cataracts. So sensory-wise, this person has decreased ability to see, of course, because they're trying to see through a cloud. Here they're showing an example of doing some padding underneath the patient's head. She's got kyphosis, got that curvature of her spine. It's almost the opposite of what we do in some pediatrics. Remember the very small peds where we pad underneath their shoulders so their head actually comes back a little bit more into alignment. In this case, she's got such a hump on her back there, they have to support under her head, otherwise her head's going to fall way back. It's going to get hyperextended. Pre-existing conditions can increase pain on exam. May already have something like arthritis that causes them to constantly be a little uncomfortable. Consider all the findings in context. Be aware of the possibility of an altered pain perception. I've seen little old ladies with pretty severe looking angulated fractures barely complaining of any pain. I've seen little old ladies take 10 milligrams of morphine like it was nothing. But 3 milligrams of morphine takes the biggest stud football player and turns him into a little puddle of a kitty on the laying on the floor. So it's very odd how pain and pain control agents affect people so differently. Sometimes if they've had surgery to fix a cataract, the pupil will not be round. It'll be what's called a keyhole pupil. So it's almost like they went and to cook a slice of pie out of part of the iris. I'm sorry, out of the pupil. well, the iris would be the color part. So causes them to have that weird shape. Don't force their neck back beyond the normal range. Use towels to help maintain alignment. Wheezes, bronchi, and crackles or rales are all signs of a respiratory or cardiac issue, maybe a cardiac issue that is showing up in the lungs. Just real quickly, remember that wheezes are typical of constriction of the airways. Bronchi are the heavier, thicker, mucousy sounding bubbles that are found in the bronchioles. Crackles or rales, that's the very light, thin, bubbling, almost Rice Krispie-like sound that you hear when you have fluid in the alveoli. Look for edema, both around their ankles, which is common, and in their low back, particularly if they're bed confined. If they're bed confined and their legs are always at the same level, the lowest part of their body is actually going to be right above their butt. Be aware of variations in presentations of illnesses and injuries in the elderly. Everybody's so different, it's possible that we have, two people who seem to be just alike have the exact same condition that shows up two completely different manners. The patient can be very, very ill yet complain of very little pain. Some can have a lot of severe infections without fever. It's not common, but it does happen. And then never take the elderly patient's complaints lightly. Remember, they're probably not sensing the full picture. Therefore, you don't get the full picture. So remember, as we age, we don't do quite a good of a job as clearing our drugs from our bodies. Possibility of buildup, possibility of negative side effects. Don't assume that the patient is an unreliable source of information, and carefully reassess their mental status. Treatment generally remains about the same. We just might have to modify it to accommodate the change in the body. So whether it's padding underneath the head because of the kyphosis, being more cognizant that the patient maybe gets cold quicker, so we maybe need to be a little quicker getting a blanket or two on them. Airway management and ventilation can be a challenge, whether it's a very stiff neck, maybe it's because we don't have a nice firm surface to put a mask on, because those teeth don't have any, the dentures don't have any adhesive on it, and they're just kind of floating in there. Controlling external bleeding, again, can be a big problem. Depends on what types of medication they're on. Elderly patients can easily be overloaded with fluids. Now, granted, most elderly patients are chronically dehydrated. It's funny to say this, and I've said it before, but many times elderly patients are considered instant people, just add water. Most elderly people can take a little bit of water, a little bit of fluid, but it is so easy for it to get out of control. And with as many people with hypertension and congestive heart failure that we deal with, a little bit too much becomes a big problem real quickly. The thing about rehydration, the patient did not get dehydrated in 5 minutes. We are not going to rehydrate them in 5 minutes. We're just going to overflow their body with fluid. So slow infusions of fluid is great to help rehydrate them, but dumping tons and tons in them if they've already got fluid on their lungs is really going to create an issue. Remember, reassessment is, again, at 5 and 15-minute intervals depending on their condition. And we continue to monitor our treatments that we perform, our primary assessment, their complaints, any changes based off of any treatments that we've done. Remember to trend our findings. So that's why multiple sets of vitals are required. We got to take multiple sets to see, are we doing anything? Are they getting better? Are they getting worse? Are they staying the same? Adjust your impression. So adjust the patient's priority, adjust your treatment plan. We don't always get it right the first time. Sometimes we take a leap of faith and say, this is what I believe is going on, so I'm going to try to treat it this way. And if that doesn't do it, we'll change. We'll do something different. Of course, give the elderly patient the respect that he or she deserves. It's always a good idea to start with Mr. or Mrs. or Ms. And their last name. They may ask you to then call them by their first name, and then by all means, call them what they request you to call them. Don't use the terms of endearment, sweetie and honey. That's condescending. Really driving this point home. Don't speak to the family members or caregivers instead of speaking to the patient. You talk to the patient first whenever possible. Make eye contact, listen patiently, give them time to respond. The ability to live independently can evaporate on an instant, leaving elderly dependent on others. One of the biggest concerns that patients have when they call 911 is that ambulance could come pick me up, and it could be the last time I ever live by myself in my own home. So hospitals can trigger painful memories. They may have lost loved ones there. Be empathetic. Don't minimize their fears. Be reassuring. Ask them if they would like you to lock up, turn off the lights, turn on a light, check something before you go. Make sure you have the important things for them to live. Can we get your glasses? Can we get your dentures? Can we get your hearing aids? Are there any things you're going to need for the next couple of hours or so, or maybe a day or so while you're in the hospital? We're not going to pack their house. We're not going to pack a giant suitcase for them. But some of those things, they need to be able to see. They need to be able to eat. They need to be able to talk and hear. So having some of those important items, even though they may not have a mom at the time, we can take a moment and get those. Keep them warm, protect them from the elements, cover their head if necessary, and then handle them gently and respectfully. Remember that sometimes they're a little fragile. All right, keep the patient warm, protect them from the elements. Tell them what you're doing before you do it. You should do that with all patients. Talk to the patient during transport about their life and history. Be beneficial to the patient and informative to you. I've met many, many, many interesting people on non-critical transports, whether it be from one hospital to another or even on a 911 call, and have found some of the most awesome things that have happened to people living right in our own communities. Had some very wonderful people that I've met along the way. And sometimes you just being there to listen and talk to them is one of the best things for them, because they don't get visitors as often as they used to. All right, I'm going to cut us off right there for now.